Hello, everyone. Welcome to the module on lower gastrointestinal and pancreatic malignancies. I am Dr. Courtney Cavalieri, clinical oncology pharmacist at the Huntsman Cancer Institute at the University of Utah in Salt Lake City, Utah. This presentation is part of the ASHP-ACCP Oncology Pharmacy Specialty Review course, which is designed for pharmacists seeking to obtain recertification credit or update their knowledge and skills in preparation for board certification. The activity is designed to be interactive with questions posed to you at several points. I will pause to allow you time to consider how you would answer the question. You may wish to write down your answer and the correct response in your handout. The disclosures are displayed on this slide. And the learning objectives for this module are provided for you here on the next 3 slides, as well as in the handout. Of note, this presentation will cover colon, rectal, and pancreatic cancers. Anal cancer is covered in the handout only. The learning objectives listed on this slide are covered in the handout only. We'll start off the presentation by discussing early stage colon cancer. Beginning with a case, LS presents to the oncologist for discussion of adjuvant treatment. She is 6 weeks out from a laparoscopic right colectomy, which revealed a T4A N0M0 disease with high-risk features. Which of the following is the most appropriate adjuvant therapy for LS's stage 2B high-risk colon cancer? A, observation, B, capecitabine, C, Folfox, or D, FOLFIRI? The most appropriate answer is B, capecitabine. A is incorrect because for patients with stage 2 high-risk colon cancer, it is recommended to give them capecitabine or 5-FU infusion if they don't have other contraindications. C is not the most appropriate answer at this time, as the addition of oxaliplatin to a fluoropyrimidine has not been shown to improve outcomes for stage 2 disease. And D is incorrect at this time because FOLFIRI has not been shown to provide survival benefit in the adjuvant setting. When we talk about early stage colon cancer, we're talking about stages 1, 2, and 3. The overall goal for these patients is to cure them of their disease. Our treatment modalities are similar to those we see in other solid tumors. We use surgery, chemotherapy, and to a more minor extent, radiation. Surgery generally involves a partial colectomy with complete resection of the primary tumor and a minimum of 12 lymph nodes. For early stage colon cancer, chemotherapy's role is typically in the adjuvant setting, and it's utilized to eradicate any micrometastatic disease and has been shown to improve disease-free survival. Radiation, as I mentioned, plays a very minimal role for early stage colon cancer. We see it play more of a role in early stage rectal cancer. As pharmacists, we will focus on the systemic therapy portion for early stage colon cancer. So in general, the principles of adjuvant chemotherapy. We ideally want to begin treatment between 4 and 8 weeks after surgical resection to achieve the best outcomes. The duration across all stages is typically 3 to 6 months, and we'll get into which patients can receive 3 months versus which patients can receive 6 months. Fluoropyrimidine-based regimens are the standard of care, so this is either with 5-FU or capecitabine with or without oxaliplatin. In terms of overall benefit in survival outcomes, there hasn't been shown to be any benefit for stage 1 patients, and therefore they do not receive any adjuvant chemotherapy. Stage 2, we see a minimal to moderate benefit, and stage 3, there is a definite benefit to adding adjuvant chemotherapy after surgery. This slide provides for you an incredibly brief review of the history of adjuvant chemotherapy for early stage colon cancer. The Exact trial showed that capecitabine is clinically equivalent to 5-FU and leucovorin. The Mosaic trial, which I'll go into a little bit more in depth on the next couple of slides, showed that the addition of oxaliplatin to 5-FU improves outcomes, but specifically for stage 3 patients. The last trial here showed that Capox is an acceptable alternative to Folfox and therefore can be used in place of it. The Mosaic trial is probably one of the most significant landmark trials for adjuvant chemotherapy in colon cancer. This trial randomized stage 2 and stage 3 patients to either receive 5-FU leucovorin or Folfox4 regimen. The overall results for the entire population did show a statistically significant increase in 6-year overall survival from 76% to 78.5%. And of course, the Folfox regimen was associated with higher rates of adverse drug reactions. When the authors broke down the populations into the stage 2 and stage 3 patients, they actually saw that the addition of oxaliplatin to 5-FU did not statistically significantly affect the survival outcomes for the stage 2 patients. However, the survival outcomes still did do better with oxaliplatin for the stage 3 patients. So the Mosaic trial, to boil it down, showed us that for stage 3 patients, the addition of oxaliplatin does improve disease-free survival and overall survival. However, for our stage 2 patients, they can be successfully treated with 5-FU alone. Folfox was associated with higher rates of adverse drug reactions, which is unsurprising, including neutropenia, anemia, thrombocytopenia, diarrhea, nausea, vomiting, and peripheral neuropathy. So this is an important reason why not to add oxaliplatin to our stage 2 patients to save them from some of these adverse drug events without the increase in survival benefits. So now if we break it down into specifically stage 1, stage 2, and stage 3 patients, stage 1 patients will undergo surgical excision of the primary tumor and the appropriate number of lymph nodes, and then be followed with surveillance. For stage 2 patients, it does get a little bit more complicated. There are a few considerations we have to take into account. One of those considerations are if patients have high risk factors for recurrence. These include things like a T4 tumor, so a larger tumor, poorly differentiated histology, lymphovascular or perineural invasion of the tumor, bowel obstruction, localized perforation, close, indeterminate, or even positive margins, and an inadequate sampling of lymph nodes, so less than 12. The second consideration for stage 2 disease is if patients have defective DNA mismatch repair, or dMMR. For a more in-depth review of dMMR and microsatellite instability, I will refer you to the pharmacogenomics module. However, how it pertains to stage 2 colon cancer is that there have been many studies that have shown stage 2 patients who are dMMR or microsatellite high actually have a good prognosis with just surveillance and do not benefit from 5-FU adjuvant therapy. Therefore, all stage 2 colon cancer patients should be tested for dMMR status because they can actually avoid adjuvant chemotherapy if they are dMMR or MSI high. So now with those two big considerations, we can look at our stage 2 patients If a patient has stage 2 low-risk disease, so doesn't have any of those high-risk features, they undergo surgery, and then after surgery, if the patient is a low-risk dMMR or MSI high, they can undergo observation or potentially a clinical trial. These stage 2 low-risk patients can be considered for adjuvant therapy. Again, that's only for the patients who are MSI stable or proficient in MMR. And the adjuvant therapy that's currently recommended is either single agent capecitabine or 5-FU and leucovorin. For patients with stage 2 disease with those high-risk features, once they undergo surgery, it is recommended for them to receive adjuvant therapy with either capecitabine or 5-FU leucovorin. You can consider adjuvant therapy with FOLFOX or CAPOX. However, the addition of oxaliplatin, based on the Mosaic Trial, did not improve survival outcomes and just increased toxicities. So this consideration should be heavily weighted. If patients are otherwise not amenable to chemotherapy or they have comorbidities contraindicating them from chemotherapy, you can consider observation after surgery. When we look at stage 3 disease, we are going to see these patients undergoing surgery and then receiving adjuvant therapy with either FOLFOX or CAPOX. Now, up until a couple years ago, it was recommended for all patients to receive 6 months of therapy. However, there was a consortium of trials called the IDEA trial that collaborated with 6 different randomized trials and looked at patients with low-risk stage 3 disease and high-risk stage 3 disease. They were looking to see if 3 months of therapy was non-inferior to 6 months of therapy. They did find that for low-risk disease, 3 months of CAPOX was non-inferior to 6 months of CAPOX for disease-free survival. However, non-inferiority of 3 versus 6 months of FOLFOX has yet to be shown. In high-risk disease, they saw that 3 months of FOLFOX is inferior to 6 months of FOLFOX for disease-free survival, and that the non-inferiority of 3 months versus 6 months of CAPOX has not been shown. So what this boils down to is that for our low-risk stage 3 patients, 3 months of CAPOX is an acceptable treatment regimen. However, if the patient's treated with FOLFOX, you can ideally go up to 6 months. For our high-risk patients, you can either do 3 to 6 months of CAPOX or 6 months of FOLFOX. I will note that with the most recent NCCN guideline update from this past January, they did remove the Category 1 designations that you see here on this slide. So now moving on to early stage rectal cancer. Again, this includes stages 1, 2, and 3. Our goal is still to cure these patients. We're going to see the same 3 treatment modalities of surgery, radiation, and chemotherapy. However, we're also going to see chemoradiation used in these patients. For the surgery, we're still going to want to examine at least 12 lymph nodes. Radiation plays a much bigger role with early stage rectal cancer than with early stage colon cancer. We see radiation used most commonly in the neoadjuvant setting prior to surgery. However, it is also used in the adjuvant setting as chemoradiation. Chemoradiation can be used in either the neoadjuvant or adjuvant setting. In the neoadjuvant setting, it has been shown to improve the resectability of the primary tumor. And so this is a very common neoadjuvant treatment for these patients. Chemotherapy is also used in both the neoadjuvant and adjuvant setting. In the neoadjuvant setting, it improves resectability of the primary tumor. In the adjuvant setting, it eradicates micrometastatic disease and improves disease-free survival. Staging rectal cancer is a little bit different than early stage colon cancer. Patients are first staged clinically, and this is through imaging upon diagnosis. The clinical stage helps determine whether neoadjuvant therapy should be given before surgery. If the patient does then undergo neoadjuvant therapy, they'll receive that, then undergo surgery, and then based on the findings in the surgical resection, the patient will then be pathologically staged. This pathologic stage determines the plan for after surgery. If patients did receive neoadjuvant chemoradiation, they are recommended to receive adjuvant chemotherapy. Now, what exactly we do for early stage rectal cancer gets very, very tricky, and it's a little bit difficult to summarize everything on a couple of slides. So I will refer you to the handout for a more in-depth discussion. So neoadjuvant therapy may include short course radiation, which is just radiation alone, chemoradiation, which is also known as long course radiation, or chemotherapy, or sequential treatment with any of the two or all three approaches. Total neoadjuvant therapy, or TNT, is an approach that you'll see referred to with the treatment of early stage rectal cancer. And this is where patients receive both chemotherapy and chemoradiation prior to surgery without any adjuvant therapy. So essentially, they're receiving everything that they can prior to surgery to maximize surgical outcomes. For patients who have indication for adjuvant therapy typically includes either chemoradiation or chemotherapy alone, or sequential treatment with both approaches. If patients receive radiation in the neoadjuvant setting, they do not receive radiation again in the adjuvant setting. However, if they receive chemotherapy in the neoadjuvant setting, they can indeed receive chemotherapy in the adjuvant setting. Although the choices of what exact treatments these patients receive can be a bit complicated, the regimens are a little bit more simplified. Our chemoradiation regimens are typically either capecitabine, infusional 5-FU, or bolus 5-FU with the radiation. These patients receive the chemotherapy on every day that radiation is given. The chemotherapy regimens that we see for these patients are either FOLFOX, CAPOX, or 5-FU leucovorin or capecitabine. This slide is an incredibly oversimplification of the treatment algorithm for clinical stage 1 and clinical stage 2 and 3. I'll refer you to the figure in the handout for the full algorithm, which is on pages 18 and 19. For clinical stage 1, these patients are typically undergoing surgery, followed either by observation or adjuvant therapy. For clinical stages 2 and 3, these are the patients that are typically undergoing neoadjuvant therapy before surgery, followed by adjuvant therapy, or they're receiving the total neoadjuvant therapy up front, followed by surgery, followed by observation. Once both our early stage colon and rectal cancer patients receive their therapy and complete treatment, there are recommendations from both the NCCN guidelines and the ASCO guidelines on how to follow these patients. And follow-up includes colonoscopies, physical exams, CEA, and CT scans at periodic intervals that are listed for you on the slide. And with that, we will move on to stage 4, or metastatic colon and rectal cancer. Although the early stages of these diseases are treated differently, in the stage 4 or metastatic setting, they are treated the same and therefore will be combined for the rest of this section. So starting off with our case, EH was recently diagnosed with metastatic colorectal cancer. Next generation sequencing results for his tumor are KRAS and TP53 pathogenic mutations. MSI stable, and a tumor mutation burden of 8. His past medical history includes controlled hypertension. Which of the following is the most appropriate initial therapy for EH? A. Capecitabine. B. Folfox plus cetuximab. C. Folfiri plus bevacizumab. Or D. Folfoxiri plus panitumumab. The correct answer is C. Folfiri plus bevacizumab. This is an acceptable option for first-line treatment of metastatic colorectal cancer in patients who are eligible to receive intensive therapy, which EH is. Controlled hypertension of note is not a contraindication to receive bevacizumab. Answer A is not the most appropriate at this time, as EH is otherwise eligible to receive intensive therapy. If he was not, then single-agent capecitabine could be considered. Answers B and D are inappropriate because EH does have a KRAS mutation, making him less likely to respond to EGFR inhibitors, cetuximab, and panitumumab. So looking at our treatment modalities for metastatic colorectal cancer, the goal for the majority of these patients is palliation. However, you'll see under our little surgery bullet that there are about almost a quarter of patients who can undergo surgery, usually with adjuvant or even neoadjuvant chemotherapy, and can often be cured. This is elaborated a little bit more in depth in the handout, and I will also touch on this at the end of this section. Chemotherapy is really the workhorse in our metastatic colorectal patients. Chemotherapy palliates symptoms and has been shown to prolong survival to up to 24 months. Fluorouracil and capecitabine-based regimens are the standard of care. And typically we're giving chemotherapy in a sequential fashion based on pertinent biomarkers, previous therapies, and patient comorbidities, including lasting side effects from previous therapies. Radiation does play a role, but really in a palliative sense to relieve either pain from tumors and or bleeding. Over the next few slides, we're going to delve in our first-line options for treatment of metastatic colorectal cancer. In terms of first-line options for chemotherapy, our fluoropyrimidine-based regimens are the standard of care. Studies have shown that capecitabine is considered equivalent to 5-FU, and therefore these can be switched out with the regimens you use, mostly based on patient preference or patient access to either capecitabine or pump disconnects for the 5-FU. Folfox or Folfiri are superior to 5-FU alone, and we know that Capox is non-inferior to Folfox. So what this means is that typically we're not giving these patients just 5-FU or just capecitabine alone if they can tolerate regimens such as Folfox or Folfiri. We also know that you can use either Folfox or Folfiri first. There are no differences in progression-free survival or overall survival, only the different toxicities we see with the different regimens. And therefore, we're going to sequence these either Folfiri then Folfox or Folfox then Folfiri. We can combine all of the drugs together in the regimen Folfoxiri. So this includes 5-FU, oxaliplatin, and irinotecan. This regimen was compared against Folfiri and improved response rates, progression-free survival, and overall survival. Now, of course, because we're combining all of our kind of standard chemotherapies for colorectal cancer, this can increase toxicities, and therefore we want to very carefully select the patients who receive Folfoxiri in the frontline setting. So with that, we have our chemotherapy backbones. Now we can consider adding on to the chemotherapy backbone. So bevacizumab has been studied quite extensively in the first-line setting and has demonstrated improved response rates, progression-free survival, and overall survival when added to fluoropyrimidine-based regimens. Therefore, we can add bevacizumab onto any of our chemotherapy backbone regimens. So whether that's a fluoropyrimidine single agent, FOLFOX or CAPOX, FOLFIRI, or FOLFOXIRI. Another addition to our frontline chemotherapy backbone can be the anti-EGFR monoclonal antibodies. These are cetuximab and panitumumab. However, we do know that mutations in RAS and BRAF do predict lack of response to EGFR inhibitors. Therefore, it is recommended that all patients with metastatic disease undergo tumor testing for KRAS and NRAS mutations, as well as BRAF mutations. If patients do not have mutations in any of these, they are considered wild type, and only the wild type tumors or patients should be eligible for the anti-EGFR monoclonal antibodies. If patients are RAS or RAF wild type, they, as I said, are eligible, and either cetuximab or panitumumab have both shown improved response rates and progression-free survival when added to either FOLFOX or FOLFIRI, but they have not been shown to significantly improve overall survival. The NCCN does support the addition of these to either FOLFOX or FOLFIRI in the frontline setting. However, there is a growing body of evidence discussing primary tumor sidedness and its effects on how patients respond to these anti-EGFR monoclonal antibodies. So this growing body of evidence shows that patients with right-sided RAS wild-type primary tumors actually confer little to no benefit from an anti-EGFR monoclonal antibody. So although these patients are RAS wild-type, who you would think would otherwise be eligible for these agents, if they have a right-sided tumor, they actually will not benefit. Therefore, the NCCN panel recommends that patients with left-sided RAS wild-type tumors only be offered the anti-EGFR monoclonal antibodies in the frontline setting. One of the most exciting things to happen with metastatic colorectal cancer within the past year is the addition of immunotherapy in the frontline setting. So we've known for quite a few years that patients with dMMR or MSI high disease respond better to immunotherapy, and specifically our PD-1 inhibitors. The KEYNOTE-177 trial looked at patients who were previously untreated, who had dMMR or MSI high metastatic colorectal cancer, and randomized them to either pembrolizumab or chemotherapy. They showed improvement in progression-free survival and are hoping to see an improvement in overall survival, although those data are still maturing. Based on this study, the FDA did approve pembrolizumab in the frontline setting for these patients, and the NCCN guidelines support this use as well. So now to summarize all of that information into what exactly do we give these patients in the frontline setting. Essentially, patients are grouped into one of two categories. Either they can tolerate intensive therapy or they cannot. For patients who can tolerate intensive therapy, we're giving them one of those chemotherapy regimens plus a targeted agent, so either bevacizumab or one of the EGFR inhibitors if they are RAS or RAF wild type. Pembrolizumab is, of course, indicated if patients have dMMR or MSI high disease. With the most recent update in the NCCN guidelines, they now also support nivolumab with or without ipilimumab in the frontline setting for these patients, although pembro is still the preferred agent. For patients who are not eligible for intensive therapy, we're seeing more single-agent regimens used, so a single-agent fluoropyrimidine with or without Bev, cetuximab or panitumumab, or one of the immunotherapies if patients have dMMR or MSI-high disease. We're also seeing growing evidence of using our HER2 regimens for patients with HER2-amplified disease. And with the most recent NCCN update, they actually did add famtrastuzumab deruxtecan as another initial option for patients with HER2-positive RAS/RAF negative disease. So once we give our patients our first-line therapy, we're hoping to palliate them and extend their survival for quite a few months, if not years. However, we do realize that patients will eventually progress. In general, patients with metastatic colorectal cancer are treated continuously with systemic therapy in a sequential fashion. At some point in care, it is recommended patients should receive a fluoropyrimidine, oxaliplatin, irinotecan, an antivascular agent, and an anti-EGFR monoclonal antibody if they are RAS/RAF wild type. Now, these agents can be given in combination with each other. They can be given as single agents, but the key to improving survival in these patients is really to expose them to all of these agents at some point in their care. We do have some data on the targeted agents, and so we'll start with antivascular therapy in the subsequent line setting. Bevacizumab can actually be continued from frontline therapy into the subsequent line setting. The continuation of Bev has been shown to improve progression-free and overall survival over just continuing chemotherapy alone. Our other two antivascular agents are zivafliprcept and ramucirumab. These have both been studied with FOLFIRI after progression on an oxaliplatin-containing regimen, and this regimen could have been used with or without bevacizumab. The NCCN guidelines do state, though, that bevacizumab is the preferred anti-angiogenic agent based on toxicity and cost. The anti-EGFR monoclonal antibodies have also been studied in the subsequent line setting and are recommended to give in combination with either irinotecan as a single agent, FOLFOX, or the FOLFIRI regimen. However, unlike bevacizumab or the anti-angiogenic agents, it is not recommended to continue an anti-EGFR mAb if a patient has already progressed on one in another setting. So, for example, if a patient receives FOLFIRI cetuximab in the frontline setting, once they progress, they should not receive either cetuximab or panitumumab in the subsequent line setting. So these agents are kind of like a one and done type deal versus the antivascular agents can be used in any line setting continuously. Now, something to note that's quite interesting with metastatic colorectal cancer is that patients with BRAF V600E mutations have been noted to have worse outcomes. Now, extrapolating from disease states such as melanoma, the BRAF targeted regimens have been used in these patients, but actually with worse outcomes than using just chemotherapy on its own. This is because blockade with BRAF inhibitors, with or without MEK inhibitors, results in feedback upregulation of EGFR, and therefore these agents have to be used with anti-EGFR therapies. The regimen that is now recommended is encorafenib with cetuximab or panitumumab, and this is only for patients who haven't received any of these agents prior. So this regimen is recommended based on the results of the Beacon CRC trial. This was a phase 3 trial investigating encorafenib plus cetuximab with or without binimetinib versus investigator's choice chemotherapy. So there were 3 arms to this trial, essentially the triplet regimen of encorafenib, cetuximab, binimetinib, a doublet regimen of encorafenib and cetuximab, or the control arm of chemotherapy. The results were only compared to the control arm, so the triplet and the doublet were not actually compared against each other. And both the triplet and the doublet regimens did show improvement in overall survival versus the control arm of chemotherapy. The triplet therapy arm did have higher rates of grade 3 adverse drug reactions, and really based on these higher toxicities as well as a decent overall survival result, the FDA only approved the doublet regimen. The NCCN guidelines do support using panitumumab in place of cetuximab if that's the choice of the treating physician. Now, as I mentioned in the slide for patients who cannot tolerate intensive therapy, we do see patients with HER2 positive disease. However, there's very, very few of them. There's only about 3% of metastatic colorectal cancers that are HER2 amplified. The same principles from breast and gastric cancers apply, so same testing principles and same, positivity treatment correlations. And we have seen decent response rates to the HER2-directed therapies in heavily pretreated colorectal cancer patients. The regimens that are recommended per NCCN are trastuzumab, either with lapatinib or pertuzumab. And as I mentioned before, fam-trastuzumab deruxtecan is now an option as well. Patients should only receive these if they are RAS/RAF wild type and have not received any previous HER2-directed therapies. We have a couple of oral agents that are approved in the subsequent line setting. Both of these agents, regorafenib and trifluridine tipiracil, were compared to best supportive care after patients had progressed basically on everything else. So patients had to have had received a fluoropyrimidine-based therapy, irinotecan, oxaliplatin, bevacizumab, and an anti-EGFR monoclonal antibody, if appropriate, for their tumor type. Regorafenib is a multi-targeted kinase inhibitor. It increased overall survival and progression-free survival, but with many, many adverse drug reactions, specifically including hand-foot skin reaction, fatigue, diarrhea, hypertension, and rash. Because of the poor tolerability of this agent, there was a trial looking at titrating the dose instead of starting off with the typical 160 milligrams daily for 3 weeks on and 1 week off. And so if you're nervous about patients being able to tolerate this drug, the titration is a worthy alternative. Trifluridine tipiracil was approved based on the Recurrence trial. So this is a pyrimidine analog plus a thymidine phosphorylase inhibitor. It's kind of a similar concept to using 5-FU with leucovorin. Trifluridine tipiracil was shown to increase overall survival and progression-free survival as well as disease control rate with tolerable adverse effects, mostly including myelosuppression. Now, because this is a typical chemotherapy, it is dosed based on VSA and the trifluridine component. So it's 35 milligrams per meter squared per dose, twice daily on days 1 through 5, 8 through 12 of a 28-day cycle. It's a little bit confusing to say out loud, but when you look at a calendar, essentially patients can take this on a Monday through Friday, then Saturday and Sunday off, then the next Monday and Friday, and then have a little more than 2 weeks off before they start the next cycle. The most recent NCCN guidelines now also support using trifluridine tipiracil with or without bevacizumab in the subsequent line setting. So before immunotherapy was recommended and approved in the frontline setting, we knew it could improve outcomes in the subsequent line setting. So both Pembro and Nivo, with or without IPI, have been shown to increase progression-free survival in patients with dMMR MS-high disease. However, it is recommended that if patients had received any immunotherapy in a previous line, they should not receive it in the subsequent line setting. Therefore, patients who have received Pembro or Nivo, with or without IPI, in the frontline setting should not receive subsequent immunotherapy once they progress. As I mentioned in the beginning of this metastatic section, there are patients who present with essentially resectable metastatic disease. Typically, these patients have a primary tumor that is amenable to resection, and the metastatic sites are either solitary liver or lung metastases. Now, patients can receive surgery up front, so resecting the primary tumor and the single site of metastases, followed by adjuvant therapy. Or there's another recommendation that patients can receive perioperative chemotherapy. The recommendation is that this perioperative chemotherapy should not exceed a total of 6 months of therapy. So basically, patients will receive a little bit of neoadjuvant therapy and undergo resection, and then complete 6 months of systemic therapy adjuvantly. So if they received 2 months in the neoadjuvant setting, then they'd complete with 4 months in the adjuvant setting. Basically, any of the regimens that we use in metastatic disease can be used for these patients to convert them to resectability. If a patient with stage 4 disease has undergone resection and has no evidence of disease, the NCCN guidelines and ASCO guidelines do have recommendations for follow-up, relatively similar to the recommendations for patients with earlier stage disease. So with that discussion of metastatic disease, I will now move on to some supportive care topics. We'll return to EH. So EH presents today to begin treatment with FOLFIRI and bevacizumab. During the irinotecan infusion, he experiences abdominal cramping and diaphoresis. He also experiences an episode of diarrhea. What is the most appropriate intervention to alleviate EH's symptoms? A, give atropine and consider pre-medication with atropine for future cycles. B, give loperamide and counsel EH to take loperamide around the clock at home. C, give octreotide and consider pre-medication with octreotide for future cycles. Or D, give tincture of opium and counsel EH to take tincture of opium around the clock at home. So I hope, based on EH's symptoms, that you've recognized this as a cholinergic response, and therefore A is the most appropriate answer. We're going to give atropine and consider pre-medication with atropine in the future. Answers. So the rest of these agents will not receive cholinergic reactions. Answer B is incorrect because loperamide would be more considered for delayed diarrhea. Answer C is incorrect because typically we reserve octreotide for complicated delayed diarrhea or diarrhea that's refractory to loperamide. And D is also incorrect because usually we reserve tincture of opium for patients with persistent uncomplicated diarrhea. So now discussing chemotherapy-induced diarrhea as a whole, we know that any chemotherapeutic agent can cause diarrhea, but we do know that high rates of diarrhea are reported with agents such as irinotecan, the fluoropyrimidines, methotrexate, cytarabine, some tyrosine kinase inhibitors, the immune checkpoint inhibitors, and stem cell transplant conditioning. For our colorectal patients, it's quite notable that chemotherapy-induced diarrhea has been reported in up to 80% of patients receiving 5-FU and an irinotecan. If a patient does present with diarrhea that we think is due to their chemotherapy, we don't want to just kind of put our blinders on and assume it's just the chemotherapy. You do always want to evaluate the patient as a whole and consider any other contributing factors, including their underlying malignancy, if they're also receiving radiation to that area, other medications, any neuroendocrine or psychological factors, as well as the other ones listed here. Now, irinotecan-induced diarrhea is kind of its own special issue. I'll refer you to the handout for more detailed information on UGT1A1 and SN38, which is the active metabolite of irinotecan. There are various mechanisms by which irinotecan and SN38 are proposed to cause diarrhea, and it's differing if it's acute diarrhea or delayed diarrhea. So the definition of acute diarrhea is that it occurs immediately or within 24 hours of the infusion. And we're thinking that this is due to the direct inhibition of acetylcholinesterase by irinotecan. And so that's why we're seeing the cholinergic symptoms such as abdominal cramping, lacrimation, salivation with the acute diarrhea. Delayed diarrhea is defined as occurring after 24 hours post-infusion. And we're thinking this is primarily a secretory process with exudative properties. This is thought to be due to the reactivated form of SN38 via bacteria that produce beta-glucuronidase in the gut. So we know that UGT1A1 is responsible for the glucuronidation, essentially the inactivation of SN38 to SN38G. There are polymorphisms we see in UGT1A1 that cause lower expression and therefore decreased SN38 glucuronidation. Patients who are homozygous for the UGT1A1 star 28 allele are at the most risk for severe toxicities, including diarrhea and neutropenia. There is an approved test for UGT1A1 alterations. However, there are no formal guideline recommendations on when to use this test. It really, from what I've seen, has depended on the particular physician and whether or not they feel patients should always be tested before initiating irinotecan. There are dose modification recommendations in the package insert for irinotecan. So if a patient does come back either heterozygous or homozygous for that star 28 allele, you can refer to the package insert for dose reduction recommendations. When we're evaluating a patient with diarrhea, we actually want to compare their current stooling to their baseline stooling, and that will give us a grade in order to appropriately treat these patients. When we talk about treatment of chemotherapy-induced diarrhea, this module does not cover the treatment of immunotherapy-induced diarrhea or colitis. I will refer you to the melanoma module for that. But I will talk about irinotecan-induced diarrhea and then all of our other chemotherapy-induced diarrhea. So for acute irinotecan-induced diarrhea, again, we know this is a cholinergic reaction, and therefore we're going to use anticholinergic agents. Atropine is the recommended agent. We usually can start off with a dose of 0.25 milligrams IV or subcutaneous up to a cumulative dose of 1.2 milligrams. Delayed irinotecan-induced diarrhea is managed similar to other chemotherapy-induced diarrhea, which I'll cover on the next couple of slides. We're going to break patients down whether they have an uncomplicated or a complicated chemotherapy-induced diarrhea. For uncomplicated, we can typically get away with non-pharmacologic management, or we can introduce pharmacologic management if we feel necessary. And we can consider holding chemo for grade 2 chemotherapy-induced diarrhea. For patients with complicated CID, Typically, these patients need to be admitted to the hospital and discontinued on their chemotherapy, particularly if it's an oral agent. And this is where we're going to consider adding octreotide. This slide provides for you the dosing recommendations for the agents recommended in the guidelines for chemotherapy-induced diarrhea. I will note, though, that these guidelines were published in 2007 and therefore are in need of some updating. In addition to the agents on the previous slide, other agents for chemotherapy-induced diarrhea include diphenoxylate, of course with atropine, budesonide, absorbents, and probiotics. I'll refer you to the table in the handout with more detailed information on the agents presented on this slide and the slide before. We'll now move on to the second supportive care topic that's being covered in the presentation. RL recently started FOLFOX plus panitumumab and presents today for cycle 3. She reports a new rash that is pruritic, occasionally weeps pus, and extends over her face and chest mainly, and partially covers her back. She states she has been compliant, taking her doxycycline since she has started treatment. What is the most appropriate intervention for RL's grade 2 rash at this time? A, continue panitumumab at the same dose and change the doxycycline to minocycline. B, continue panitumumab at the same dose and initiate topical hydrocortisone. C, dose reduce panitumumab and initiate topical salicylic acid. Or D, dose reduce panitumumab and initiate oral prednisone. The correct answer would be B. Since RL's rash is categorized as a grade 2 rash, the most appropriate therapy would be to continue the panitumumab at the same dose and initiate therapy with topical steroids in addition to the oral tetracycline. Answer A is incorrect because there's currently no evidence that minocycline is any more effective than doxycycline. Answer C is incorrect because we wouldn't need to dose reduce at this time. That's reserved for a grade 3 or 4 rash, and topical salicylic acid is not recommended for EGFR rash. Answer D is incorrect, again, because we don't need to dose reduce panitumumab at this time, and oral prednisone is reserved for grade 3 or 4 rashes. So the rash that our poor patient has been experiencing is officially known as the EGFR inhibitor Papulopustual rash, otherwise known as an acneiform rash. It's the most common adverse drug reaction seen with our EGFR inhibitors and our anti-EGFR mAbs. The incidence is up to 90% of patients receiving these medications and can typically be seen within the first 2 weeks of treatment. The rash is characterized by papules and pustules coupled with pruritus and pain. It's known as the acneiform rash because it's distributed in our seborrheic areas such as the face and scalp. It is not acne, though, as there are no comedones and the histopathology is different. The one positive thing with this rash is that there has been shown to be a positive correlation between rash severity and occurrence with overall survival and tumor response, and therefore it's really important to manage the rash so that therapy can continue for these patients. Listed for you on this slide is how we grade the acneiform rash. This is also provided in the handout. So we do actually know that the management of the acneiform rash is actually a little bit more successful if we initiate preemptive management for at least the first 6 weeks of treatment. This includes hydrocortisone 1% with a moisturizer on the face specifically, encouraging the patient to use sunscreen, and initiating doxycycline 100 milligrams twice a day. If patients either do the preemptive management and still get the rash, or if they didn't do the preemptive management and still get the rash, we do also have reactive management. So we want to initiate any of the therapies listed that are not already in use. So for grade 1 rash, we can typically continue the dose, initiate topical hydrocortisone if not already using, and topical clindamycin. For grade 2, we still want to continue the dose, initiate topical hydrocortisone, and then ensure the patient is taking their oral doxycycline and or minocycline. For grade 3 and 4, this is when we're going to start to dose reduce the agent per the package insert. And in addition to the agents already mentioned, we're also going to consider using oral prednisone. So those are just 2 supportive care issues that our colorectal cancer patients face. However, there are a lot of survivorship issues that we do have to attend to, including late sequelae of the disease and or treatment, so fatigue, chronic diarrhea and incontinence, or oxaliplatin-induced neuropathy. Some of these are addressed in the handout. We also want to encourage patients to continue with a healthy lifestyle and wellness, which includes healthy body weight and physical activity, and there is support for using daily aspirin in these patients for secondary prevention. So that wrapped up our conversation on colorectal cancer, and now we'll be moving on to pancreatic cancer. We'll start off with JM. JM underwent a Whipple resection 10 weeks ago and is now recovered with an ECOG performance status of 0. He did not receive any neoadjuvant therapy. So which of the following is most appropriate adjuvant therapy for JM's resected pancreatic cancer? A, observation, B, gemcitabine, C, gemcitabine plus nab-paclitaxel, or D, modified FOLFIRINOX. The correct answer would be D, modified FOLFIRINOX, and this is based on the results from the PRODIGE 24 trial. Both the NCCN guidelines and ASCO guidelines recommend and support modified FOLFIRINOX as a preferred regimen for adjuvant pancreatic cancer treatment. Answer A is incorrect because JM does have a good performance status and could tolerate therapy at this time. Answer B would only be an option if JM wouldn't be able to tolerate a more intensive therapy. And answer C is incorrect at this time because gemcitabine plus nab-paclitaxel has actually not been shown to improve survival outcomes in the adjuvant setting. Our 3 standard treatment modalities are used in pancreatic cancer, so surgery, radiation, and chemotherapy. There are a few different types of surgeries based on the location of the pancreatic tumor. Radiation can be used really in any setting, neoadjuvant, adjuvant, or local control. Typically, radiation is used in combination with chemotherapy, either a fluoropyrimidine or gemcitabine, and it can also be used as palliative. Chemotherapy is typically used in all stages at some point in care. Our 2 main regimens are either gemcitabine-based therapies or fluoropyrimidine-based therapies. Now, although there is AJCC staging based on TNM, we really treat pancreatic cancer based on clinical stage. The 4 clinical stages are resectable, borderline resectable, locally advanced but unresectable, or metastatic disease. For our resectable patients, those are the patients going straight to surgery typically, followed by adjuvant therapy, although neoadjuvant therapy can be considered for high-risk cases. Our borderline resectable patients typically have tumors that are abutting major vasculature, and therefore these are the patients receiving neoadjuvant therapy, followed by surgery, followed again by adjuvant therapy. For our locally advanced unresectable and our metastatic disease patients, these are patients who are receiving systemic therapy. Sometimes the locally advanced unresectable patients may be eligible for chemotherapy and radiation. Clinical trials should be considered for all stages of disease. When we look at the different therapies, we'll start with neoadjuvant therapy. The biggest place in therapy for neoadjuvant therapy is for those borderline resectable patients. Unfortunately, there's insufficient evidence right now to recommend any specific regimen. Therefore, the acceptable regimens per NCCN are really regimens that we're going to see in the metastatic setting as well. So FOLFIRINOX, gem plus nab-paclitaxel, gem cisplatin. And then any of these chemotherapy regimens can be followed by chemoradiation. Typically, we're giving neoadjuvant therapy for 2 to 6 cycles, and these patients may also receive adjuvant therapy after the surgery, although again, data are lacking to recommend any specific regimen. So adjuvant therapy choices are really based on how the patient responded to the neoadjuvant therapy, their performance status, and the expected tolerability. Moving on to adjuvant therapy, there are a variety of trials to look at when considering adjuvant therapy, and I apologize for the text overlapping the table. However, we do essentially know that gemcitabine is better than observation. 5-FU isn't any better than gemcitabine. Gemcitabine plus capecitabine is better than gemcitabine alone, and modified FOLFIRINOX is also better than gemcitabine alone. At this point in time, we are not sure that gemcitabine plus nab-paclitaxel improves overall survival. However, interim analysis of the APACT trial showed us that disease-free survival was not significantly different. The major trial to come out in the last couple of years for adjuvant therapy was the PRODIGE-24 trial, and this was comparing modified FOLFIRINOX versus gemcitabine in the adjuvant setting. They found the disease-free survival to be improved to 21.6 months with modified FOLFIRINOX versus 12.8 months with gemcitabine alone. So what's actually recommended for adjuvant therapy for these patients? Their preferred regimens are either modified FOLFIRINOX or gemcitabine plus capecitabine. However, if patients aren't expected to tolerate either of those regimens, other acceptable regimens include single-agent gemcitabine, 5-FU leucovorin, continuous infusion 5-FU, or single-agent capecitabine. Patients can also be considered to receive induction chemo, followed by chemoradiation, and potentially followed by subsequent chemo. This slide lists for you the surveillance recommendations for patients with resected disease. The treatment regimens recommended for locally advanced unresectable disease are quite similar to those that are recommended for metastatic disease, so I'm not going to go in depth on this slide, but we're going to move on to recommendations for metastatic disease. So we'll start off with our patient case. TS was recently diagnosed with metastatic pancreatic cancer. He states he wants to fight this cancer for his family. His ECOG performance status is 0. The molecular workup of his biopsy reveals a mutation in KRAS and high microsatellite instability. So which of the following is most appropriate initial treatment for TS's metastatic pancreatic cancer? A, gemcitabine, B, gemcitabine plus erlotinib, C, gemcitabine plus nab-paclitaxel, or D, pembrolizumab. The correct answer for TS is C, gemcitabine plus nab-paclitaxel. He has a good performance status, no pertinent comorbidities, minimum symptoms, good family support, and his goal is to treat, and therefore he's a good candidate for aggressive chemo. Modified FOLFIRINOX or FOLFIRINOX would also be an option. Answer A is not appropriate because due to all the factors that I just mentioned, he would be eligible for more than just single-agent gemcitabine. Answer B is not the most appropriate at this time because this is not considered a preferred regimen by NCCN. And answer D is actually not appropriate because although he does have an MSI high tumor, pembrolizumab is not indicated in the first-line setting. This slide summarizes for you the various trials that have looked at our regimens for metastatic disease. The baseline being that gemcitabine was compared against 5-FU, and gemcitabine provided a significantly better clinical benefit rate than 5-FU alone, and therefore gemcitabine single agent has become the standard to which all other regimens are compared against. So you can see the addition of erlotinib or nab-paclitaxel has improved progression-free and overall survival. And then FOLFIRINOX versus gemcitabine alone has also improved progression-free and overall survival. So based on the results of those studies, we now have all of our recommendations. This is quite a busy table at first glance, but basically what we're looking at are the recommendations from the NCCN guidelines and the ASCO guidelines. Both guidelines split their recommendations into patients who have good performance status or poor performance status. Typically, for patients with good performance status, we're seeing more aggressive chemotherapy regimens such as FOLFIRINOX and gemcitabine plus nab-paclitaxel. If patients have a BRCA1 or 2 mutation or a PALB2 mutation, they are recommended to receive a platinum-containing regimen, so either FOLFIRINOX or gemcitabine plus cisplatin. For patients with poor performance status, this is where we're seeing more of our single-agent therapies or pembrolizumab for MSI-high dMMR tumors or some of our tyrosine kinase inhibitors. A relatively new treatment strategy in the world of pancreatic cancer is the idea of maintenance treatment. The patients who are eligible are those who have responded or have stable disease after 4 to 6 months of systemic therapy. Our options include Olaparib, but this is only for patients with germline BRCA1-2 mutations, a clinical trial if available, or if the patient was receiving first-line treatment with FOLFIRINOX or modified FOLFIRINOX, they can receive single-agent capecitabine, 5-FU with or without irinotecan if patients are experiencing excessive toxicities due to oxaliplatin, or you can also consider FOLFOX if patients have excessive toxicities due to the irinotecan. If patients were receiving first-line treatment with gemcitabine nab-paclitaxel, you could consider a modified schedule of gemcitabine nab-paclitaxel. So instead of doing a 3-week on, 1 week off, you could do an every other week type of schedule, or you can continue them on gemcitabine alone. So the one maintenance treatment I'll go into a little bit more in depth in the presentation is maintenance treatment with Olaparib. This was evaluated in the POLO trial. So patients had to have no disease progression during the first 16 weeks of a platinum-based chemotherapy. So this was most typically FOLFIRINOX. At that point, they were randomized to either receive Olaparib twice daily or placebo. This is a big criticism of this trial because we typically wouldn't stop treatment for these patients unless they were having an incredible amount of toxicities. However, the Olaparib did show improvement in progression-free survival over nothing at all, and therefore this is a recommendation for maintenance treatment in these patients. We'll now move on to what we do after our first-line treatment. So TS received 6 cycles of gemcitabine nab-paclitaxel, but unfortunately has progression in his lungs and liver. What would be most appropriate subsequent therapy for TS? A, capecitabine, B, 5-FU plus radiation, C, pembrolizumab, or D, best supportive care. The most appropriate answer would be C, pembrolizumab. If you remember, this patient is MSI high, and therefore this is appropriate as subsequent line therapy for him. Answer A would be considered only if TS had a poor performance status and if he wasn't MSI high. Answer B is incorrect. due to TS's extra pancreatic sites of disease, radiation really wouldn't do much unless we were radiating everything, which would be too toxic. And best supportive care wouldn't be appropriate at this point, as he still has a decent performance status. So when we break down our recommendations for subsequent therapy, again, we're going to be basing it on the patient's performance status, as well as what they received in previous lines of therapy. So if the patient had a prior fluoropyrimidine-based therapy, we're essentially going to be switching to a gemcitabine-based regimen. And then the opposite is true. If they received a gemcitabine-based regimen, we're going to be switching them to a fluoropyrimidine-based regimen. Now, we do actually have a recommended subsequent line therapy for pancreatic cancer, and that's 5-FU leucovorin plus liposomal irinotecan, and this was based on the Napoli-1 trial. This was a phase 3 open-label trial that randomized patients to one of 3 arms, either 5-FU leucovorin, liposomal irinotecan alone, or the combination. Both the liposomal irinotecan arm and the combination arm were not compared against each other, but only compared against 5-FU. And they both showed numerical improvement in progression-free and overall survival, but only the combination arm was statistically better than 5-FU alone. So therefore, if a patient was treated with a gemcitabine therapy in the frontline setting, this regimen is the recommended regimen for the subsequent line treatment. For patients with good performance status, here are some other options, again, including pembrolizumab for MSI-high or dMMR tumors, and then our NTRK TKIs. For patients with poor performance status, in a subsequent line setting, we're really looking at single agents. Gemcitabine can be used either as a standard infusion or the fixed dose rate, although the fixed dose rate is a category 2B. Or we can use single agent fluoropyrimidines. Again, we're still seeing pembrolizumab for tumors that are MSI high or the NTRK TKIs. With the last little bit of time, I'll focus on supportive care and survivorship issues for pancreatic cancer patients. Based on the location of the tumor, some patients do present with obstructive jaundice or gastric outlet obstruction. Both of these obstructions should be taken care of before patients are treated with systemic therapy. If these occur during treatment, then systemic therapy should be put on hold while these are taken care of. Pain is a really big issue for a lot of metastatic pancreatic cancer patients. Often, metastatic pancreatic cancer infiltrates the retroperitoneal nerves, and therefore sometimes even around-the-clock narcotics may not be effective for this pain, so patients should really be considered for invasive techniques or palliative radiation. Depression and anxiety are also huge issues for these patients. This is just due to the nature of this disease and how aggressive it is and how quickly it can take people. And therefore, patients should be continuously screened for any issues with depression or significant anxiety. Another supportive care issue we see is pancreatic enzyme insufficiency, and we actually see this both in our resected patients and our metastatic patients. This can be controlled with oral pancreatic exocrine enzyme replacement, so our pancreatic enzymes. The dose is based on the lipase component, with half the dose taken with snacks and then the full dose taken with meals. It is recommended to get the most benefit from these enzymes to take half the dose at the beginning of the meal and then half the dose in the middle of the meal. The handout does go into more details of pancreatic enzyme insufficiency and replacement. The last supportive care issue I'll touch on for pancreatic cancer patients is thromboembolic disease. These patients are at higher risk for clots. However, there's limited evidence right now to give them prophylactic anticoagulation, and therefore we just give them treatment anticoagulation. Low molecular weight heparins are preferred over warfarin, and the guidelines don't yet touch on the DOACs. We also want to avoid thromboembolic medications in these patients. So the most notable one is appetite stimulation with Megace is probably best to avoid in these patients. That concludes this presentation, and I'd like to thank you for your participation.